Well, I'm Togas Tulandi. I'm professor and chairman of obstetrics and gynecology at McGill University. I'm here with Professor Bedaiwy, who is a professor of obstetrics and gynecology and director of reproductive endocrinology of University of British Columbia. Mohamed, that was a great presentation.
We're glad to be here. Thank you, Dr. Tulandi.
Could you summarize your presentation?
Well, the organizing committee invited me to talk about endometriosis associated infertility. So I tried to communicate to our colleagues in Canada the magnitude of the problem and why we are having some challenges to manage endometriosis associated infertility, in part because of the nature of the disease itself, and in part because of the fact that the majority of the studies did not report on the real fertility outcome, which every woman would like to have, which is having a baby at the end of the day. So the live birth rate was not reported for a large number of studies. Then we discussed with our colleagues what are the options that are available for patients with endometriosis. Could they wait for some time and try on their own? Could they go for surgery? Could they go for IVF or assisted reproductive technologies? And we tried to come up with a practical algorithm that they could use in their clinical practice about which type of patients would be candidate for each one of these options.
You and I are dealing with infertile women, infertile couple. Clearly, infertile women are different than women who have completed their family. Could you comment on how we manage these people?
Well, people who completed their family and if they are dealing with endometriosis, they have probably more options because hormonal suppression with a variety of medications that we have is an effective tool that we could try. And there is a layered approach as to what type of hormonal treatment that you could start with, and if the response is not the same, you can then move to the next step. Surgery is one of the options, and if it is implemented correctly and done appropriately to address the extent of the disease in the patient, patients also do well after the surgery. However, if their ovaries are still there at the end of the surgery, most likely that they would require hormonal suppression after the surgery as well. So you and I know that some of the women would imagine that doing surgery on them would solve all of their problems. This is not true. There recurrence risk of endometriosis after surgery for patients who are still having their ovary could be up to 30-40%. So definitely that subgroup of patients are different compared to patients who are trying to achieve pregnancy as their first goal.
Could you comment how aggressive you are for women with infertility compared to women with not infertility?
Well, I'm not that aggressive, and if I could help them to achieve pregnancy with non-surgical means, that would be definitely a priority, and that should be the first choice. Nowadays, we have assisted reproductive technologies, and we have data saying that it is probably the best option for a large number of patients with endometriosis, not for everyone. However, this is complicated by the cost factor because it's not funded in many provinces, only in few. Consequently, the other factors will come into play in a non-funding setting, particularly surgery, as well as some expectant management, particularly for patients with early stage disease.
So for our infertile patients, I think we are less aggressive, and our objective is for them to have babies.
Correct.
Yeah. So would you give a comment? What do you suggest to our gynecologists who are a member of the society?
What I would suggest first, I would definitely encourage them to study the patient well. Because number one, endometriosis can come with other problems, like problems with the tubes, problems with ovulation, problems with the proper semen. and sometimes also problems with advanced age of the patients, which is probably a very important factor in predicting their ability to conceive after that. So that is the first thing that they should focus on. They should decide from the get-go, are they dealing with endometriosis only or endometriosis plus other comorbidities. After that, they have to explore the options and try to come up with a tailored plan that fits their patient needs, and at the same time address the concerns and take the cost factor into account. And if they're number three, if they decided to take this patient to the OR, they have to be very conscious all the time about the patient desires and wishes, particularly if fertility is their number one goal, to try to optimize the anatomy and probably be less aggressive with interventions with the ovary that may not make a huge difference in their pain outcomes, but they could be a serious jeopardy and serious threat to their ovarian reserve and the number of eggs that they have in their ovary.
Well, Professor Bedaiwy, thank you very much.
Thank you, Dr. Tulandi.